All right. Good morning, good afternoon, and good evening, everyone. I have no idea what day it is because I got back from Tanzania late last night. So it could be morning or evening in my head. And we welcome everyone from across the globe. Welcome to UCSF Center for Global Nursing's Impact Series. The series aims to provide a platform for our nurses and global partners to share their remarkable work, offer valuable insights, and inspire our global community. Following the presentation, there'll be a short Q&A, so feel free to write your questions throughout the presentation in the Q&A box. And for those of you that don't know me, my name is Rebecca Silvers, Director for the Center for Global Nursing, and it's my pleasure to introduce this month's speaker, a dear friend and incredible nurse leader, Mvungu, sorry. Evelyn is an advanced practice nurse and the nurse manager of the Neonatal Intensive Care Unit at Moi Teaching and Referral Hospital in Eldoret, Kenya. With more than 2 decades of neonatal experience, she leads a multidisciplinary NICU team and practices across bedside care, education, and unit management. Evelyn is committed to advocating for quality and patient safety. She develops and implements evidence-based protocols in areas such as neonatal resuscitation, infection prevention, thermoregulation, and family integrated care. She also mentors new nurses through simulation and bedside coaching. She uses audits and feedback to drive continuous improvement, and she also serves as an adjunct lecturer at the MSN Neonatal program in Kabarak University, where she teaches advanced assessment and preceptorship and supports curriculum development. We are very honored to welcome Evelyn as this month's Global Nursing Impact Series. Welcome, Evelyn from Kenya, and I will hand it over to you.
Thank you so much, Rebecca. It's an honor to be here just to share a little bit about my unit and the work that we are doing. Despite all the challenges, we're having so many wins, and I thought I'd just come and share one of the major breakthrough that we have had in the neonatal units, just so that we can all see that despite where you are, resources do not matter. You can make a difference, and you can improve care and improve morbidity and mortality, specifically for neonates, which is my heart. Thank you so much. So in this presentation, I'm just going to share about an outbreak that we had between March 2024 and April and June 2026. We had a major outbreak of MDR, multiple drug resistant Klebsiella, that we really saw a very high increase of morbidity and mortality. And because of that, we did quality improvement projects, and we are still in the process of still trying to make sure that we continue sustaining the changes that we have made. And we did see quite a dramatic or quite a huge changes and reduce in the mortality rate, despite it being multiple drug resistant. And most of it, you'll see it was a collaboration between the clinicians, the nurses, the infectious disease department, the supportive staff. So we came together as a team and came up with strategies that I'm sure if somebody somewhere they're having the same challenges, they can just replicate what we've done here. And hopefully that in the once we finish, because we are going to publish this report, this QI, next time maybe Rebecca can invite me back just to present, because we are in the process of still taking data. So she can invite me just now to give you the statistics, just in an evidence way of showing you that this is where we are, and this is what we've done, and these are some of the things that we faced, and this is how you can be able to overcome some of the challenges that we faced. So thank you so much. Okay, just dive in. So I will start with just an overview of the newborn unit and where we are, what kind the level we are in, how the unit looks like, the number of clinicians that we have, and then I'll just now dive into the outbreak and how we were able to control it. I'm not able to move the screen. I don't know why.
Yeah, I see it moving.
Mine is, I don't know why I'm not able, I can't see anything, still stuck on the, sorry for that, it's still stuck on the same slide that was there.
Do you want me to try to share the slides? But there you've changed them since, I see. What would you like to do?
Oh. I can't see. There's a first slide is different from what you have.
Yeah. Do you want to unshare and then share again and see if that helps?
Let me see.
So sorry.
It's okay. Okay, that's better. So,
Evelyn,
yes,
we,
you can see me?
we can see 2 slides now.
Then 2 slides.
Do you want to
Sorry. Let me
display?
just do that again and
Okay,
display it once more.
thank you.
Sorry for that. I'm
No,
having technical challenges today.
okay.
Can you see it now?
I
Are you
see,
able to see it
I see all of the PowerPoint.
now? The
Yes,
whole PowerPoint.
perfect.
Now, is
Perfect.
that okay?
Yes.
Ah. So, just an overview of the neonatal unit. So, it's one of the largest, the second largest, if I would say, because we have one that is in Nairobi and this one is in Eldoret, level 6. We have 2 level 6 neonatal units, and MTRH being the second largest, offering special neonatal care in the western part of Kenya. The unit is a referral facility for 22 surrounding counties. Just the context of that is that in Kenya we have 47 counties, so you can see we admit babies or neonates from half of that of half of Kenya, that is 22 surrounding counties. So then this unit was built, I would say, that is 2010, and the physical capacity for this unit was meant for. We were in a smaller unit where we were just having 10 babies, 15 to 10 babies, but then we built this unit. It is 60-bed capacity. But as of now, we operate an occupancy of 150 to 200%, meaning at any given time, I have 90 to 120 babies, and due to the immense coverage. So we have quite a lot of congestion and overcrowding in the unit. So monthly admission in a month, we see around 150 to 215 units, and the admission points being maternity unit in the teaching and referral takes about 60% of those admissions. And then we have the referral centers taking about 40% of those admissions. Majority of the admissions that we see are preterm, that is between 60 to 70% of all the admissions in the newborn unit are usually preterm babies. So when you look at the layout of the newborn unit, physically we have divided the unit into several cubicles, 9 of them, and each room is approximately 12 square meters. We have the admission room. An admission room is where we admit. So we have a phone that is, we have a referral phone, a number that is for newborn units. So every referral center that is coming or trying to refer or want to refer to us, they come through our admission room. It's not a very big room. It only has 3 resuscitators, but it's quite, it does suit and does serve the unit. So you find you have 1 nurse there and one resident and a consultant who is on call for consultation in case you need anything. So that nurse receives admissions from or receives the calls, then they triage them, and then they just distribute or admit them into or take them into the different cube according to the acuity or according to the weight. Then we have a NICU. Our NICU is a 6-bed capacity, where we do mechanical ventilation for all babies who needs an intensive care unit. Then we have high care cubicles, high care 1 and high care 2. And those ones are, high care 1 is specifically for non-invasive. So anybody that needs CPAP is admitted there. Or if you need to do hypothermia, we do therapeutic hypothermia, so we do it in that room. And something I would want to point out, for all these rooms, it's 1 nurse. So NICU has 6 beds, very sick babies, 1 nurse. High care 1 and high care 2, the approximately between 10 to 15 babies each room, and there is usually 1 nurse in that room. Then we have high care cubicle, which is where we have babies that are below 1,500 grams, and there we have incubators. And the room there is supposed to accommodate around, let's say, 6 to 5 incubators, but we have almost 12 incubators in that room. And because we have, as you can see, 60 to 70% of admissions are preterms. So in that room, you'll find baby sharing. That was one of the major challenges that we are having. So we have baby sharing. So, and you can see what happens because of that need of the space. Any baby who gets to 1,500 grams, once you get 1,500 grams, you're moved out of that room, out of the incubator, and you go to a stable room now. For stable preterm room, you have babies who are 1,500 grams and above. And in that room, once you start 1,500 and below is your period on NG tube feeding. When you get to 1,500 grams and you're stable, maybe on oxygen, you're on CPAP, now you have wind off to oxygen, or you're not even on oxygen support. Then what you do, you take them to the grower's room, 1500 above, and then you start your cup feeding. Once you start cup feeding, by the time you get to 1650, we transition, you start breastfeeding. By the time you are 1690 to 1700 grams of discharge. So you see our discharge weight is very low, and that is because you cannot accommodate to keep babies up to 2.5. So by the time a baby is 1650 grams, they're already breastfeeding off NG tube feeding, and the mom can go home with that baby, and then we follow them up on the outpatient. Then we have the stable cubicle for term babies. Now, these are babies that are maybe they're just doing conventional phototherapy, they're waiting to finish antibiotics, maybe 5 days or 6 days of antibiotics, or we're just trying to monitor phototherapy level. Then and that room also, the stable preterm room, we can just go back. Also, we hold around, the room can hold, ideally supposed to hold 10 babies, and can go up to 20 babies with one nurse. Then we have stable room, the same thing. Now it can hold approximately 12 babies to 15 babies, but ideally it should be a room that should hold 7 babies, so that takes almost double the number. Then you have the surgical, which is a new room that we introduced with some of the measures that we did for this outbreak. So the surgical room is where we admit all surgical babies. So whether you are baby has a neurological issues, a neurosurgery case, or is a urology case, or it is just general pediatric surgery, they are all admitted. And because most of these babies come from other referral hospitals, so we have that room where we isolate them there and we admit them until they are stable. If they need mechanical ventilation, it's done there. If they need CPAP, they're done there. So they don't move from that room. They only move from that room if they're being discharged. Then we have KMC. And that room ideally should hold 7 babies, but it goes as high as 15 babies in that room with one nurse. Then we have KMC. So we have continuous KMC, a room that is upstairs where we're on the ground floor. So on the upstairs, we have the second floor, we have KMC for continuous. So we continuous KMC where we have 7 beds, and there's one nurse there that mans the room. A new introduction is the isolation. We didn't have an isolation because I said space is a big issue for us, but we were able to come to talk to the administration with this outbreak, and they did provide us a space just outside the newborn unit where we are isolating babies that have positive, gram-positive or positive blood culture. So looking at the daily clinical staffing of the staffing level, so we do have 10 nurses in the unit. Those are the ones that are actively involved with the patient care, like they are the primary nurses. So out of the 9 rooms, every room has one nurse, and then we have an equipment nurse. That's one of the roles that we introduced the other day, a few years ago. And that was just to ensure that we notice that our equipment are not being taken care of very well, the cleaning. And remember, I said we are sharing a lot. So we need someone who is very keen on ensuring that there is constant, continuous cleaning of incubators. So we have an equipment nurse. We have approximately 15 students per day, medical nursing. Then you have 13 doctors, those are residents and the consultants who are manning each room per day. So consulting teams, we do have now the pediatric surgery, the neurosurgery, whichever team that has admitted a baby in the newborn unit, then they come, we work closely together with them. We also have point of care ultrasound. We try as much as possible not to move our babies out of the unit. We are the only unit that has point of care ultrasound. So we do have point of care ultrasound in the neonatal unit, and we also have an X-ray that is specifically for this unit. We also have an echo. So in case we need anything, any test or radiological examination done for that baby, so they are done. The only time we move them out is when if they have if we need to do CT scan. So physiotherapy, we work together, counseling, and we have 2 nutritionists that are there throughout the shift. So our mothers are the main caregivers for our babies, and in case the baby does not have a mother, then we have somebody who acts as a guardian, and they have to come and be introduced by the family. There's a person going to take care of that baby neonate as long as they're in the unit. So our mothers don't stay on the same level. So as I say, newborn is on the ground floor. Mother's hostel is upstairs on second floor. So our mothers come every 3 hours. So every 3 hours, mothers are always moving up and down to come and feed their babies and take care of their babies. So now we dive into the sepsis. So between March 2024 and June 2025, we had a dramatic increase in the multi-drug resistant Klebsiella. And at the height of the outbreak, I remember we used to have 2 to 3 cases per day, and sometimes even 6 cases per day of when you have positive culture coming back. And it was quite, and in a month, you could have like 50 babies that we've had positive blood cultures, and specifically the gram negative. And then at that time, we had very high morbidity and mortality among the preterm and the surgical. So preterm and surgical babies were the ones that were most affected, especially extremely low birth weight. Any baby that came with 1,500 and below, those babies were really affected. And we saw a very high mortality. Our mortality used to be around 7%, but at that time, we went as high as 20% for per 100 for all the admissions. So we usually calculate by the admission. So our mortality went very high. So because of that outbreak, we were prompted to do an in-depth review of the IPC practices. And what we did is that me as a nurse manager and the consultants, we just sat on a raise. We need to identify what are the issues that you're having. So we picked, every day we pick someone just to walk around and see what are those things that we feel are really making this sepsis to have the outbreak. So the first thing that we identified, and which we didn't have much control, that was huge overcrowding, and it's still there even now. But then we realized that if we cannot be able to take care of the overcrowding, there are things that we can do as a unit that we feel are in our control. So we also noticed that suboptimal adherence to hand hygiene. So that's one thing that we saw. We sat down and realized we are nearly having an issue with the people doing hand hygiene. So we have to come up with measures to ensure that we re-emphasize and emphasize on people now doing hand hygiene. The other thing is that we noticed was that there was contamination of services and equipment, and I will elaborate this. So out of that, this prompted us to put in measures just to mitigate the spread of this infection and safeguard the patient outcome and strengthen the IPC measures. So there are several things that we did. So for hand hygiene, this is what we did. This is what we felt as at that time. It was cost effective. There was no money that we needed to be used. We just had to come together and do something about it. So the first thing we did that nursing was a huge, I have 60 nurses, but at every given time we have 10 nurses every shift, and 10 nurses at night and 10 nurses in the evening. So we realized that we needed to re-educate. If we focus our attention on the nurses, and there's a primary nurse in the room, and educate them and sensitize them on hand hygiene, then that nurse is going to ensure that anyone who comes into that room will ensure that they follow our hand hygiene protocols. So the other thing we realize that people are just coming in the unit and going to changing, and then you go to the main hand washing. And sometimes if the hand washing is the center of the unit, they forget and they go straight into the room. So we realize for people to be emphasis on hand hygiene, what do? We just look for some funds, a few coins, and just start. We put a new hand hygiene washing point at the entrance. That way, by the time when someone comes in, the first thing you see is a sink. So you wash your hands, you go in, change, then now you go to the main hand washing, or you get inside the room, you sanitize, or you wash your hands inside. So we still have the existing main hand washing point at the middle of the unit where everybody washes hands. That one, it was being used, but we needed to re-emphasize people to continue doing hand washing. Then every room has a cubicle, has a hand hygiene sink, and with running water and soap. The other thing is also it is there, but we need to emphasize that people really have to start being very conscious that they have the first thing when you come in, there's a place for you to wash your hands, wash your hands. So we also ensure that there's soap which is antibacterial at every point of those hand washing points. The other thing is that we've never had an issue with soap, with supply of water, but then the issue to do with soap, we needed to make sure that we talk to the people that supply soap in most of the whole unit is the housekeeping. So we talked to them and emphasized that we came down and had a team with them. We sat down, we realized that for neighbor with 90 mothers or 120 mothers, we have like 25 staffs at the end of every shift. So you find that you have like 100 to 150 people at every given shift, especially in the morning session. So how many hand gel do you need? So we talked, and then now we make sure that every month we get them restocking, that we don't ever get to a point where we do not have hand washing. So to happen at that time. So the other thing we did was come up with an innovation to ensure that there is alcohol-based hand rub at every patient's bed. So you can see there's that a container there, that's a baby's cot, and then there's a hand gel, a hand rub there. So this is something that we, as a team, we contributed money, the consultant, the nurses, and we made sure out of the 120 cots that we have in the unit and resuscitate, every cot has that holder, and we ensure that every morning, as we are taking our morning rounds and we are going around with a shift, that we ensure that every morning there's those hand rub containers are refilled, and that way we emphasize that way when you come in at the court and you find there's hand gel, it's easy for you to remember to use it, even though someone is in. So when you see it, then immediately the first thing you do is use the hand gel. So that is another thing that we did. The other thing that we did that mostly we had to either contribute some funds or even get a team, try to see if we could get some friends of the newborn unit to help us just to come up with like making these signages and ensuring that the measures that we are putting in place, that we make them sustainable and which have been quite sustainable. We put in measures to make sure they're sustainable, is putting signage on when you come in at this time in the newborn, the first thing that hits you is the 5 moments of hand hygiene. Whether you are staff or whether you are mother, whoever comes in, it's a relative, that's the first thing that hits them. And then once you get in, you wash your hands. You see the hand hygiene, you wash your hands. And as you walk through the corridor of the newborn unit, along the corridor, you have the infection prevention. So there are those, they are made of wood. Every surface has those signage that shows newborn unit, wash your hands, infection prevention. The other thing we realize that for someone to be able to have that, for someone to wash their hands or to use hand rub before they touch a baby, you need a signage that is just at every cot, on every resuscitator, on every cot. There's a signage that you see when you just stand in front of a baby or a cot. What you see is notice, wash hands and use hand sanitizer before and after touching me. And that made an impact. So every ward, every baby, and every where there's a baby that is on a cot, that thing is hanging just on the wall, just to remind you of that. We also increased, the other thing, what we did was that every time, so we noticed that babies were coming gram positive or positive blood culture, but there was sometimes some babies cannot be moved out of the isolation. So we increased we came up with this. So we went, contributed a few coins and made this they are more, we call them red signs. So when you see a red sign on every cot, you know that baby, like that's a baby who is a NICU. We cannot move that baby to isolation because they are in invasive mechanical ventilation, they are in NICU, they are critical. So what do? You put a tag there so that people can be aware that this the baby is not in the isolation, but that baby you need to really enhance or ensure that you have strict hand hygiene. But then the other thing, what it is that we noticed initially when we started, mothers were getting very anxious, but then we started talking to, before you put the signage, you talk to the mom, you explain to her why the baby is like that, you tell them it's for the sake, or it's for the sake of the baby, to ensure that people are very careful in their handling and also to protect other babies. So right now mothers are embracing, and the same thing, they also know as long as my baby has that lead tag, even though they look stable, they're in the isolation, they will be in that unit for more than 14 days. So you don't have them getting anxious. I'm here for a week. Why am I not going home? So that's it. And then they also support us. Most mothers, when they see that tag, they are very keen. If they see you touching their baby without using hand, and they tell you, please, sister, or please, doctor, can you please use your hand, sanitize before you touch my baby. That is just the center of this. That is our sink, where we have also the hand hygiene. This is specifically for the mothers. The mothers are the ones use that sink. So we have the hand gel there and the signage for them to wash their hands. So when that happened, when the QI project started, immediately we identified what were the issues that were happening, and the first thing was hand hygiene. So we needed to have an assessment and see. So we have implemented this. We put the sink. We've ensured there's hand hygiene on there's soap on every hand washing point. We've ensured that there are tags showing that you make sure that you ensure that you continue. You make sure that you you wash your hands, you sanitize, use your hand before you touch him. Were people doing what we're expecting them to do? So with what we did, we realized for us to see whether our measures are really being people are doing having a follow through of the measures we put in. So we are doing what we call a 2-weekly hand hygiene assessment, and these are mostly done by me. I'm the team leader for this, or the champion for this, but a number of them, not the other in charge, does this in collaboration with one of our consultants. So what we do is that every 2 weeks we have assessment tools that we have. One is before washing hands. The other one you do it after handling a baby, before handling a baby, after moving away from a baby. So we put the 5 hand hygiene, all the 5 moments of hand hygiene, and assess. So we sit somewhere, people don't even know you're doing it. Then you just assess. Once you do that for each assessment, there's always an opportunity for one. So minutes once I assess you, you've not used hand hygiene, I stop you first and tell you, please, I tick that you didn't do, but at the same time, I tell you, just at this we do it immediately. So it's immediate one-on-one. So that next time I also assess again. So that has helped people to remember. We also do it in a very respectful manner so that people don't find like it's negative. So we observe, we give it on point and tell them, now you've not please can use your hand gel, you've moved away from the baby, I didn't see you do that, kindly remember to do that, or do it now and remember to. So that made a big difference. That has really helped. And what we do, we also have run charts. Every time we have that, we have charts and we show them that this is where we are last time, the first assessment, the second assessment, this is where we are. So that has helped. And sometimes we've seen identify that when you have a new team is when people are really not washing hands. Once we sensitize, it drops drastically. So you can see like the first assessment, 62% were not washing hands. The second assessment, you find 38%. So it's more fluctuation. So we realize, so it has to keep emphasizing until it becomes something that it has become like a second norm in the newborn unit. We actually, the other day, we were the best infection hand hygiene and infection IPC unit that was performing the best in the whole hospital. We are given a trophy for that. And this is because of doing this QI. So this is just showing you that what we are doing and how we are assessing to ensure that the QI project is something that you can actually have, it's measurable, and you can see whether it's really making a difference. And once you notice, this is what the last time people are washing hands very well when they come in the unit, then the next you see it has dropped, then you emphasize, next time you find people are washing hands very well. Now the issue was when they move out, or they are very good with washing before they touch them. When they move out from the baby, they forget. So we keep re-emphasizing, and that has really made a big difference. So the other thing that so that was purely on hand hygiene, and we are still assessing and it's still ongoing. As I said, hopefully by the end of the year, we are hoping we've still continued despite it starting last year. So we are still continuing because we realize we really have to make sure that we get to a level where our sepsis level has significantly gone down. We are hoping to get to a level of 1 positive culture in a month, and that's where then now we see how we can we see the changes that we can actually now comfortably publish. So the other thing we noticed was to measure to improve cleanliness and safety during invasive procedure. So once we realized hand hygiene had really picked very well, we still noticed that we still had babies coming back. Yes, the number had dropped, but we still had babies having positive culture. So when we looked at the next thing is we realized that some of the things, one of the major things we're having is this IV insertion and blood sampling. We didn't have clean IV insertion, and there was no safety in it. So what did we do? So what was happening? So for procedure safety, what we did was before patients were being taken to the admission. Remember, I said there are three resuscitators. The lighting is good. There is overhead. It's overhead, and then you find that you're able to stand and you don't have to bend all the time, and then all supplies are there in the admission room. So we realized that people are taking babies in the admission room for procedure. So you could find babies just lining up, waiting to be fixed, IV line, waiting to samples to be corrected. And then what happens that one bed had multiple use, but then people were forgetting. So when you sat there, you could see a baby comes in, they take samples, they fix a line, and you find that the doctor or the nurse forgets to clean that cot. So we realized there was a lot of contamination at that time. So when we asked them why they're doing that, most of them said, in admission room, you're having everything. In admission room, there's good lighting. So what we decided was we introduced what you call a procedure tree, and you can see that was a procedure tree for admission room. So we did, every room has, depending on the size, if admission is one, if it is in NICU, you have like two. So we introduce this admission tray. And what happens that before you move, you go to any baby, you don't move your baby, you go to your room, ensure that you have your procedure tray. If you need to fix a line for that baby, just pick all the supplies you need for that baby, go on that cot, fix the line, fix the brancard, remove the samples. Once you move from that baby, go back to the procedure tray, the main procedure tray, decontaminate, take more supplies and go to the next baby. And that has made a big difference. We are still now emphasizing, because as I said, when you have a new team, you find things don't really land the way you want. So that has made a big difference. And we've seen that now babies are not just being done, the procedures are being done in the room, supplies are adequate, and it has made a big difference for when it comes to cross-contamination or infection. The other thing that as a unit we did was environmental cleaning and disinfection. As I said, we are overcrowded, and with overcrowding makes cleaning very challenging. So we do have 3-hourly cleaning in our newborn unit, but then you ensure that if you have 120 babies, 120 mothers, like in the morning shift 9 a.m., you have 120 babies, 120 mothers, you have more than 15 clinicians on the floor, you have more than 10 nurses, then you have student medical, so it can get so congested. So despite how much well you clean every 3 hours, sometimes it's very hard to disinfect and clean. So what did we do? We sat down and said with the housekeeping department that is in charge of cleaning the hospital, around the hospital. So we decided every twice a week, we do a thorough scrubbing of the hospital using a disinfectant with germicide. So they come in initially on a Saturday when there is no much flow in the unit, and we allocate or we assign one nurse who is a team leader to ensure that babies are moved away from one room or from the room, or they just move them at the center, they scrub on the side, then they put. So it is usually quite a very tedious and a very tiresome thing, but that has made a big difference. So every twice a month we do that. Fumigation, we do it every 3 months, but the frequency sometimes is also depends on degree of overcrowding. If I have 120 babies, I have nowhere to move babies for fumigation. So we're usually very keen to track. We have a way we track. So if we get to a level where they're 85, that's when we scrub. Or it gets to 70, which is very rare. So if you get to 80 and you see this is the lowest you've been in 3 months, we try as much as possible to fumigate, and we find a way of moving or telling mothers to do kangaroo as we fumigate, and then we clean and then we move them. So there's a way we try to organize it. The other thing was equipment. As I said, we have sharing of incubators. And so what we do is that we ensure that incubators, ventilators are scrubbed after every use and in between patient, and the equipment has really made a big difference. We used to do our biomedical engineering used to do this, but then we had a lot of issues because then you find it's only one biomedical engineering for the whole building, which you have newborn on the ground floor, we have first floor, which is antenatal. So it was quite challenging. So we talked to the nursing administration, and they allowed us at least to have one nurse there are 2 nurses that do rotational, so they work in shift, so they're able to ensure that our equipment are clean. One thing that we've not been able to do when it comes to environmental cleaning and disinfection, it is to do surface swabbing. We haven't swabbed for almost, I would say, 5 years. And even with this outbreak, we're not able to swab. And that is something, it's more to do with the microbiology, the capacity to do swabbing for the whole hospital. But we are hoping in the near future, that is something that we can do, because sometimes we despite all the measures we put in place, we find that we're still having quite a few number of babies having Klebsiella, and sometimes at the back of mind we are wondering, is it because there's a surface that where maybe there's an incubator that is a source of that? So despite us scrubbing, it would be very good for us to do swabbing, but we haven't been able to do that. The other thing that we did, we were doing patient cohorting in different rooms, but then we were not doing isolation. So what we did was for all surgical babies. A few months ago, we didn't have a surgical room. Surgical babies were being missed with medical cases. because we couldn't have a place to isolate them. But when we had this outbreak, we sat down, as I said, as a unit. We went to the administration, the CEO, and then we identify a few friends of the newborn unit where we talked to them and requested, is it possible that we can get a room outside and help us to furnish it a bit for it to be an isolation? So we have now a surgical room, because we realize majority of these surgical babies, most of them, as I say, they're very susceptible to infection, because remember, they have an open wound, like a gastroschisis baby. So if you have a baby that has sepsis, chances are that baby is going to be the first baby that is going to get infected if you don't actually do your IPC measures very well. And sometimes with IPC measures, they're still very vulnerable and they get sepsis. Other things that we also know is that some of these patients were index cases for infection. So sometimes we have a new bag that comes in. We have a new bag of late, which is a weird bag. We haven't seen it for quite some, but then we realized that bag came from a baby from another hospital. So, and that's when we're not isolating surgical baby. So now every baby that comes in, all surgical babies are isolated in one room. If and then cultures are taken on admission. If we get a positive culture, we isolate them at a certain place for all surgical babies. And then those babies that are inborn or babies that are not septic and not surgical, they're isolated in the isolation room. So surgical babies, we cohort them and isolate them in one room. The other thing we did was creation of a new isolation, I said, cubicle, where all positive blood culture are isolated in this room. Remember, I said we're working together with infectious disease. So what happens once we get the first kill in the morning, they come and say we have a positive culture. That baby is immediately moved out of moved out of that room and taken to the isolation. Now, if isolation is not possible, like a baby is if the room is full, that room I think can accommodate. It's meant for maximum 7 babies, but I say it goes up to 15 babies. So if the room has already 15 babies and you cannot really isolate those babies, what do? We do cohorting. So we put the red tag that I showed you, the red tag, and then you cohort them at a corner or a specific corner in that room, and that helped to reinforce strict hand hygiene. So that is what now for patient cohorting and isolation. So sometimes you find units where we've gone places where they do not have space for isolation. The cohorting can really make a big, and it has made a big difference, and it has helped us with managing the sepsis. So we cannot control IPC or do IPC measures without working together with the infectious disease and finding a way of identifying these cases as early as possible before the sepsis or the infection spreads. So we also did what you call microbiology rapid response. How did we do this? So in collaboration with infectious disease and RAB, what we did was we asked them, okay, I know we wait for 72 hours to get blood culture. And sometimes if I have to wait for you to get the culture and sensitivity, it used to take 5 to 7 days. For those 5 to 7 days, this newborn who is having Klebsiella, this newborn who is having Pantoea, so you find such a baby who has Klebsiella and MDR. That baby will stay with other babies that are not septic for more than 7 days, and then in the process, the others will get infected. So we asked them, is there a way we can identify this baby? Even once I take a culture today, is there a way you can make me aware that this baby has we've been able to isolate gram negative? So what we did, they said, yes, we can give you a gram stain. So that gram stain, we get it within 24 to 48 hours. And what happens that we have a contact person in the lab department. So every morning, if there's a positive culture, initially we used to get like 10 or 5 in a day. So in the morning they come in, then you have to isolate and cohort all those. But now I can go even 2 to 3 days without even getting a pink slip, because most of the time I'm the one who received this pink slip. So this is, you can see on the left side. The left side, the name of the patient, then they tell you gram stain. The minute I get this, you isolate, you do early what has done that we isolate them early and start antibiotic. If they're on first line antibiotic, then we know that our baby, the eclampsia that we have is sensitive to either our second line cefepime-amikacin or imiropenam. So you change the antibiotics as you wait for the sensitivity to come. You go to the second line as you wait for the sensitivity to come, so that you can now try to change the antibiotic as per sensitivity. And this has made a big difference. So babies are isolated within 24 to 48 hours. And so we end up protecting or ensuring the other babies do not get the sepsis. The other thing is daily tracking of the positive culture numbers. So this is the tracking, the daily tracking sheet that we have, and this is in my office. So every day when they bring a pink slip, I tick, and at the end of the month, we're able to see the graph of what happened. So initially, you could find from the 1st to 30th, you have 5 days. Today I got 6 positive blood culture. Yesterday I got 2. So you need to a graph that was just going up and up. But of late, as I said, sometimes like 2 months, last month, we only had 10 positive. So when you look at it, you compare where we were and where we are right now, there's a huge difference, and something that we can support with evidence because we've been tracking all these things. So what are we doing? So all those things we've done, have we stopped? No, we're still monitoring. It's also ongoing, the monitoring and an evaluation. So what are we doing? So we have regular tracking of positive blood culture. I said that one has continued, and we will, even after this period has ended, we are going to continue doing the tracking so that we can be able to at least to make it sustainable. Hand hygiene, we are still continuing 2 weekly hand hygiene audits. That is, and we end up after every 2 weeks. When you do a hand hygiene, we just post it on our board, and people can see where we are. And then we are also ensuring that we keep track of availability of alcohol-based wrap. This is something that if you're not keen as a department, sometimes there's a huge shortage in the hospital. And so for newborn unit, we've come in an agreement. We've come to an agreement with the IPC department that there is not any given time that we'll not have alcohol-based wraps for the newborn unit and the so. And then continuous sensitization of the staff on IPC measures. So in summary, have we been able, we've not really won. We're still having to face numerous challenges with controlling the sepsis. But that doesn't mean we are giving up. We still have to keep pushing on. So we still continue doing our best despite the resources, having resources that not very, with all the resources that we have available, things that we can do without overstretching ourselves, without needing a lot of money, or just in collaboration with different departments, we've been able to do quite a lot. So what are the ongoing challenges? Overcrowding, that is still a huge thing. And we've gone into talks long term. We are hoping to build a newborn unit that can hold at least a capacity of 200. There are talks that are going on with well-wishers. Hopefully we can build a standalone newborn unit where it has 200 bed capacity. And that really has impacted the hand hygiene. So it's easy to do hand hygiene with 50 babies than 120 babies, or with a floor that has more than 150. But we're really trying as much as possible to do our best. And also, as I said, to do proper environmental disinfection is still hard. And so but that doesn't mean we are giving up. We are still pushing on. And we've seen quite huge impacts. Our mortality has gone down significantly, and the numbers have gone down significantly of positive cultures. High number of rotating. This has been the child. I remember one time, some visiting friends came from the US, and they could not understand how we have so many students. But remember, we are level 6, and level 6 is a training institution. So we have so many students coming in, and you cannot turn them away because this is their training center. We have mothers and caregivers and doctors. So that is still a challenge, but I'm hoping that when we get a bigger newborn unit, then that won't be a challenge because we just have rotating. So that thing, we've talked to the institution and the hospital and agreed that at any given time, that's an agreement we had a few weeks ago, at any given time, we have 15 students only, regardless whether they are from different institution of nursing school, we can only take 15. And that the outbreak helped us to negotiate that. Before, it was very hard to negotiate for having a specific number, but we're able to negotiate that. So a lot of sharing is there across the patients due to resource limitation. As I said, I only have a room that can accommodate maximum 12 incubators, and that is squeezing them together. So if I have, and I said 60 to 70% of those babies are preterm. So if I have like 80, 20 babies that need to be in an incubator, that means every incubator, a mother will share with another one, not twins, different mothers sharing. So if that baby gets sepsis, the other one gets sepsis. And these mothers tend to sleep all of them in one hostel. So there's a lot of sharing, and that is still an issue, but we're hoping that something that can be done in the near future, that we can have space and they'll stop sharing. Inability to separate cohort inborn versus outborn. So our babies, remember we said we are a referral hospital. So the inborns born in MTRH, we mix all of them with outborns and also referrals. So we mix all of them together, which makes it quite hard to do infection prevention from admission. So if we are mixing the 20 babies, some of them have been born here where sepsis is not very high. They're coming from born outside, but they're admitted from home or admitted from referral, other, whether it's a medical case and they're mixing together, especially if it's a medical case and they're mixing together with the babies that are inborn. So it becomes very hard to do infection. But in the near future, as I said, space is an issue. When you get space, we can comfortably say this side is for inborn and that side is for, or this newborn unit, this ward is for outborn, and the next ward is for referrals or outborn. So challenges also, the final thing that is a huge challenge for us is introductions, or we've not been able to introduce central lines, which really is going to make a big difference when it comes to IV line insertions. As I said, 60 to 70% are preterm and surgical. If you have a baby that is 1,000 gram, you don't have an umbilical line and a PICC line. Chances are every day that baby has to be pricked because there is a lot of infiltration of the IV line. So if you a baby staying with you for a month might be pricked so many times, and that is also a source of infection for most of these babies. So that has really impacted us. The same thing with surgical babies. So we are hoping our plan for 2025 or 2026 is that we try to talk to the hospital, see if they can be able to procure and help us to get umbilical lines, and then after a baby on admission, we put an umbilical line, so you're able to draw samples and give fluids on that. Then at the 7 days, we transition to a PICC line, and that baby won't be pricked for more than 30 days because that is 7 days plus 21 days, and that will make a big difference. So that is one of the goals in 2026, and hopefully we'll be able to implement that. Thank you so much. Questions?
Evelyn, this is amazing. It's incredible what nurses can do when they partner, like you said, across departments to really
Yes.
implement change and
Yeah.
create and change patient care outcomes with, as you mentioned, with not dealing with what you have and not saying, well, the answer is staffing or the answer is a bigger unit. You're taking what you have and really creating an impact. And for those of you that don't know Evelyn very well, I can tell you that her work as an APN, a nurse manager, and a leader is truly remarkable. And when I went, I think it was 2024, there was a physician strike and there were no consultants, and Evelyn's in there running all the show, and she's just incredible. And what you've done is, and what you're doing, and to continue to measure, is really valuable. And I know we've run over time, but there is one question in the chat from Josephine, who's in Uganda, and she said, "Evelyn, do you have any arrangements for babies born before arrival? I have a feeling that those babies are a major source of infection for infecting other babies."
Sorry, I haven't. Just repeat that. Do we
Yeah.
have?
Do you have arrangements like a separate place for babies born before
No,
arrival?
no, no. No, no, that's what I say. That's one of our major challenges. You've not been able to separate between an inborn, outborns, and a referral. So we still mix them up, and that is a challenge for us. Space is a huge issue. So that is one thing that we really hope that, and I'm sure if we are able to implement that, our sepsis level will go down. So we've not been able to do that. But I'm sure in the near future, we hopefully that when we get space, we're still fighting for space, and I'm sure we are going to get there. Then we can separate the outbounds and the inbounds.
Amazing. Well, thank you so much for your presentation and sharing your expertise with our community. We are so delighted to have you and want to thank you so much for joining us today. Thank you, everyone, and hopefully everyone has a wonderful day or evening wherever you are. Thank you so much.